So next one is hyperleukocytosis. This will be going, so it is going to be bombarding. There are so many conditions which usually makes the child goes into ICU. So what is hyperleukocytosis? WBC, hyper is high, leukocytosis is WBC, right? So high WBCs. So what is the criteria? What usually take as more than 1 lakh WBC, we say that it is hyperleukocytosis. Definitely this goes as a risk factor for the previous condition, that is tumor lysis syndrome. If this starts lysing, definitely the child will go into tumor lysis syndrome. So you need to be worried about tumor lysis syndrome also. But per se, it causes some issues. So this much WBCs will make the blood very thick. Blood need to be in one specific viscosity. If you put a lot of WBCs, then it will become more thick. So more thick blood will not go so easily into the vessels. It will not flow in the vessels so easily. Definitely it causes sluggish flow, right? So sluggish flow can get obstructed, can get clogged. So that clogging is called as thrombi, right? So then when it becomes thrombus, that can cause a lot of issues. If it gets blocked in the brain, it is stroke. If it gets blocked in the lungs, it is lung injury. It can damage kidney, it can cause splenic infarcts, it can cause metabolic alterations and renal failure also, okay? Just because of the numbers and because of the high viscosity, these problems can occur. They may be presenting asymptomatically, but sometimes they can have respiratory symptoms, SOB, tachypnea, decreased lung sounds, hepatosplenomegaly, oliguria, anuria, blurred vision, headache, and CNS symptoms. Okay? So like agitation, confusion, delirium, stupor, coma. These are some of the symptoms which are because of the sluggish blood flow. Okay? So you need to get that WBC down as soon as possible and try to decrease the viscosity. So how do you do that? By giving hydration. So you will start hydration for them and try to see that their hyperuricemia management is done, because they are also prone for developing tumor lysis syndrome. You need to monitor and correct electrolyte imbalances. Organ function should be managed, and chemotherapy or leukapheresis should be done. Leukapheresis is removing the WBCs. Okay, so excess WBCs will be removed by putting a machine, right? So coming to this febrile neutropenia, as the word says that it is fever with neutropenia, right? So what is fever? Definition of fever is if the child has 101 degree Fahrenheit and on a single oral temperature, or has 100.4 degree Fahrenheit sustained for 1 hour, then it is called as fever. Okay? And what is neutropenia? Neutropenia is the absolute neutrophil count less than 500 or expected to fall below 500 within 48 hours. Okay? So this is the definition. If this definition fits in, that the child will be classified as febrile neutropenia. So febrile neutropenia is a medical emergency. It is very much equal to any emergencies what you see, like heart attack or stroke. If you feel that those are emergencies, this is one other emergency, which is at that level, right? So you should never tell that febrile neutropenia is not an emergency. It is a great medical emergency. So we say that there are from profound neutropenia and prolonged neutropenias, depending on the WBC neutrophil count. If less than 100 is profound. If the neutropenia is lasting for more than 7 days, it is called as prolonged neutropenia. This is some of the definitions which are used for that. So what is special about this? This is the pyramid, how it proceeds. So child will have febrile neutropenia. Once you see that the child is having febrile neutropenia, it can be because of the bacteremia. What is bacteremia? Because of the bacteria infection. Okay? So if there is a bacteria in the blood, it will cause septicemia and it will lead to septic shock, and this will lead to death. So it will lead to death, right? So, and there are some steps which are followed like this. So if there is a bacteremia, septicemia happens, septic shock happens, and then death. So what is the time period between these two? It is estimated that it will go about 2 hours. If you don't treat these patients on emergency basis, bacteremia will become septicemia within 2 hours, septicemia will become septic shock in 2 hours, and septic shock, if you don't treat, within 2 hours the child is going to die. So it is definitely an emergency. For 7 to 8 hours you are trying to see, you are seeing that the child may die, right? So septic shock is more important to see that this is a situation where you will be seeing the child in ICU. Febrile neutropenias most of the times will be managed in wards itself. So septic shock when the child develops will go into ICU. septic shock is nothing but it's a systemic response to the pathogens and endogens that leads blood leading to poor tissue perfusion, cellular hypoxia, and also death, right? So if there is poor circulation because of bacteremia and also the endotoxins which are released by the bacteria will cause poor perfusion. Okay, so when there is poor perfusion, they will be having this complication. So it can cause hypertension and poor perfusion because even after giving fluid resuscitation. So the risk factors are again neutropenia, poor skin integrity, invasive lines, and immunosuppression. So complications are definitely, as I told you, that death is a major complication of this. So what are the clinical symptoms? We see temperature, definitely the patient will be having fever, tachycardia, tachypnea, WBC can be low, and we divide this septic shock into two categories, whether it is compensated or decompensated or uncompensated. In compensated situation, you see that the child is anxious, lethargy, flushed, instant capillary refill is there, peripheral vasodilatation, and still the BP will be normal. So that is what makes the shock as a compensated shock. If the BP goes wrong, then it is uncompensated shock, right? How do we manage? We need to manage with IV antibiotics or antifungal, whatever that cause of that septic shock. Hydration is important and vasopressors to keep the BP normal and also monitor the organs for their organs functions. So we have done with the first, that is oncology emergencies. The second category was complications because of the treatment that we are going to treat. So that is also called as iatrogenic. Complications which are developed because of the treatment that we are giving. Right? So the in that, most important is febrile neutropenia. So in that febrile neutropenia, because we already covered it, we'll see there are some specific sepsis which usually happens because of the treatments. So that is typhlitis and some other organ toxicities which can happen because of the chemotherapies, like pancreas can go wrong, liver can go wrong, CNS, heart, kidneys. Some of the complications which can happen because of surgeries, like GI surgery and brain surgeries, they usually are very comorbid situations. When they get operated, usually they land up in a lot of issues. Okay, so I will be discussing only two conditions in this, that is typhlitis and one organ toxicity. Okay, so typhlitis comes from the word typhon, that is meaning cecum. Cecum is the part of the large intestine. Initial part of the large intestine is called as cecum. Okay, so many a times it can involve the ileum also. Ileum is the distal part of the small intestine. So this part gets inflamed many a times with infection. Okay, so it can also be called as neutropenic colitis, necrotizing colitis, ileocecal syndrome, or cystitis. So these are some of the synonyms to typhlitis. Okay, so this is pretty common to see, and it is very important for you to know because it is a great challenge for you to manage these kids as a dietitian. So what happens? Why these children have this? It can be because of Clostridium septicum or Pseudomonas aeruginosa, which are the most common organisms which are found to cause this condition. So this usually is seen post chemotherapy. Many a times in children we see because of high dose chemotherapy what we give in AMLs, they usually have this typhlitis. Okay, so they present with fever, severe crampy abdominal pain, more localized towards right quadrant, right roll. If they start complaining of pain abdomen, which is localized right lower abdomen, then probably you always should be suspecting that there is a chance that the child is developing typhlitis. So there can be abdominal distension with diminished or absent bowel sounds, vomitings, and septic shock. If a child is complaining of abdominal distension, how do you treat this? You are not supposed to pump in your food continuously. If the child is not tolerating it, there is some problem with the intestine, right? So you are supposed to be giving bowel rest to that. You cannot push in, if not, the bowel will even perforate, right? So you need to have a bowel rest, you need to give bowel rest. Of course, antibiotics will be administered. Supportive medications matters a lot in this condition. I with giving hydration with IV fluids, octreotide, vasopressors, antacids, analgesics, and taking help of TPN. So surgery is if the child develops a perforation. Okay. So coming next, this is the last condition, that is pancreatitis. So pancreatitis, I always say myself that this condition should never happen to the child. Why is it? Because of the pain that gives to the child. Okay, the pain that a child experiences because of this pancreatitis is worst. So this is one of the worst pain that can happen. Pancreatitis is inflammation. Itis is inflammation, pancreas. So pancreas inflammation. So it can be acute or chronic. The risk factors are plenty. But when it comes to childhood cancer, we see because of the drugs like L-asparginase, which is a part of ALL treatment, 6-mercaptopurine, again a part of ALL treatment. Steroids can also cause it, diuretics, radiation to the left abdomen, diabetes, tumor lysis syndrome, post-HSCT infection are some of the other causes of pancreatitis. Okay? So what is the pathophysiology of this? How this pancreas gets inflamed is that whenever, like for that sake, I'll just take the example of L-asparginase. When we give L-asparginase, the drug will cause the damage to the pancreatic anatomic integrity. So once it starts damaging, once it initiates the damage, it causes activated pancreatic enzymes to leak into the pancreatic enzyme. So when the drug damages the pancreas, it will cause release of enzymes. That release of enzymes will cause autodigestion of neighboring pancreas. So autodigestion, the enzyme which is released because of the damage, the enzyme will digest some of the part of the pancreas. That pancreatic damage will release some more enzymes, and that enzyme will cause autodigestion. So it is an ongoing process. So that gets into a vicious cycle. Okay? So then once you initiate it, that will take care of itself. That's how it happens, right? So that continuous damage and release of enzymes will be happening, and then that leads to pancreatic abscess, necrosis, hemorrhage. It can cause GI bleed, hypovolemic shock, renal failure, ERDS also. Okay? So it's an ongoing process that continues for a long time. They usually present with diffuse abdominal pain and or rigidity. So if the child lands up in very severe kind of pancreatitis, they usually will have very restless. They won't be lying down smoothly, peacefully on the bed. They will be very restless. And even though you go ahead with a lot of pain management, still they will be having a lot of pain. They will usually have nausea and vomiting. Fever, diaphoresis is a part of that. Tachycardia, tachypnea, hypertension, dehydration symptoms can go. And once you feel that everything is fine, you start feeding them, the symptoms will come back. So that is called as post-eating. There will be stimulation of the pancreas, and that causes severe pain. So that's why children will not like you all when you start telling them that you eat when they have this pancreas, correct? So this is a situation where you should try to avoid them when you want to feed them. If not, they'll start hating you also. So in laboratory wise, when you see that they will be having elevated amylase, lipase, elevated WBC, hyper or hypoglycemias, glucose can go up and down because pancreas has something to do with insulin. So, and then they can have high lipids, low calcium, low albumin, elevated CRP and LDH because many a times they will also develop secondary infection. So how do you treat? So we treat by removing the contributing causes. What is the cause for that? You need to identify and try to avoid that cause. Second one, you should treat the associated infections. I said to you that once there is a damage, it opens up and it forms an abscess there or necrosis there. Whenever there is a necrosed material in the body, definitely bacteria will be very happy. They get a lot of food there. They go sit and then nobody is there to cover. So then they will be proliferating easily. So that forms abscess. So you need to treat associated infections. You need to correct the coagulopathies, diet and nutrition, and pseudocyst management. Pseudocyst management is when there is an ongoing process. As I told you that there is enzyme release, autodigestion, enzyme release, autodigestion. There will be some necrosis formed, abscess formed. Then it will form a cavity. It's a pseudocyst, what we say. Okay, that's a sequelae of pancreatitis. So how do you manage diet and nutrition in this patient? Of course, the child will be on bowel rest, right? You are not feeding the patient for a while. Once you plan to start, how do you start? Clear liquids, ORS. Okay, so is it enteral or parental? There are two schools of thoughts that whether to treat these kids with parental nutrition or enteral nutrition. Okay, so and then this is the best method to see rather than reading individual papers. You see that meta-analysis where they looked into all the published data of total parental nutrition versus total enteral nutrition in predicted severe acute pancreatitis patients. Okay? So the result was, so total enteral nutritional support is associated with lower mortality, fewer infectious complications, decreased organ failure and surgical intervention rate compared to parental nutrition. Okay? So even though it looks like total parental nutrition would be the one which is probably the best, but the studies favor total enteral nutrition. Okay? I end here by saying a famous quote by Hippocrates that cure sometimes, treat often, and comfort always.